Hello, everyone. Thank you so much for joining us for today's research series, Tier 2 session, Community Engagement and DEI in Research. Our presenters for today's session are Dr. Kathy Hosig, who is an associate professor in the Department of Population Health Sciences at Virginia Tech. She is also the director at the Center for Public Health Practice and Research and is a public health extension specialist. Additionally, Dr. Hosig co-leads the Community and Collaboration Core within iThrive at the Virginia Maryland College of Veterinary Medicine. Our other presenter, Dr. Jaclyn Nunziato, is an assistant professor in the departments of Obstetrics and Gynecology and the Health Systems and Implementation Science Department. She's assistant clerkship director in Health System Science with focus on the policy and advocacy domain. Dr. Nunziato is a graduate of the 2021-22 Teach Health System Science and Interprofessional Practice Clinical Champion faculty cohort. Additionally, she is the executive director and founder of Huddle Up Moms right here in the Roanoke Valley. Drs. Hosig and Nunziato, welcome. I'll now turn things over to both of you.
Thank you.
Thank you very much. We're going to try going back and forth between us and hope that goes smoothly, because we felt the way that we wanted to approach the material, it worked best that way. So please bear with us as we do that. I'll do the learning objectives, and then Dr. Nunziato will move into the goals related to that. So as you know, because this is a continuing medical education event, we needed to have learning objectives. And so we came up with ones that we think are appropriate for the topic that we're talking about today. So first of all, just making sure that at the end of our presentation, our participants would be able to see at least 2 benefits of community engagement and DEI in current or future research that they're involved in. And then making it a little more personal, making sure that participants would be able to discuss at least one strategy, hopefully more, to engage members of communities that are affected by their current or future research. And the last one, of course, participants will be able to discuss at least one strategy to enhance DEI in their current or future research agenda. So we're hoping that you can take away from our presentation things that you'll be able to use in the work that you're doing.
And then I always like to do goals. I think it's interesting to do these, to be on these continuing learning, because usually when you're in this environment, if you're coming to the presentation, you already have an invested interest. And so we know that we're speaking to kind of like-minded individuals and open to learning. So really some of our goals is we just want you to be able to kind of define and redefine what it means to be community, and what community-based research could look like, and how you can incorporate it into your own research. We want you to know why it's important, and why it's really critical to engage the community when you're thinking about even creating a research project. We wanted to kind of help you understand what some of the key elements are for engaging in the community and really focusing on DEI. As always, whenever we're trying to do anything new or innovative or integrative, there's always barriers, especially I find when it comes to research on the clinical side. And then how do we create innovative strategies? So it's not enough to kind of talk about what some of the barriers and the problems are, but we wanted to give you some tangible solutions to incorporate it. And then Kathy and I are going to end with some applications on how we've kind of tried to blend and have both community and DEI focus throughout our research, and then give everybody in the audience kind of opportunities to ask questions and tell us about your research and kind of how, if you want some application or solutions to some of the barriers that you've faced.
So when we're talking about community, I find that defining who the community is in each particular project or the work that we're doing is really helpful, because, for example, in our work with iThrive over the last 5 years, which is an integrated translational health research institute of Virginia, it's a clinical translational science award. A lot of what we do is engage with communities, and we found ourselves thinking, well, who is our community? And it really is important to think about who are you trying to engage with and for what purpose in your particular situation. But when we think about community, it can be defined in a lot of different ways, as you can see here on the slide. But a generally good way to think about it is the group of people that share characteristics that are relevant to the topic that you're talking about, or the topic at hand, or the research. And so I'll just read the first bullet. A group of people who are in a particular space have shared values and interact within a social system. And that helps define who is the community for the topic that you're working on, or the research agenda that you're working on. Types of characteristics can be all the things that you see on this list. So it doesn't necessarily mean that it would be, for example, everyone from a single race. It could be people who are in a certain geographic region, and you would want to actually have a diverse population in terms of race from that same region. So it really is important to think about what are the characteristics and the similarities of the group of people that bond them together, or that connect them in a way that you would interact with them to find out more about them, to inform the research that you're doing, or to find ways to serve the community that in particular that you're working with in that particular scenario.
So when it comes to the medical model versus community health, I think it's kind of important to emphasize the difference between the two and how the two can work together. My background has always been in nonprofit work in public health and population health. And one of the reasons I wanted to become a doctor to begin with is really to make a dramatic change and influence people's lives. And the more I got into medical school and residency and clinical practice, the more I realized that health is just so much more than the diagnosis. It's more than the person, right? It is the overall environment and community that they come into the hospital system with. And that sometimes there are barriers and limitations within the hospital system and the confines of the actual clinics that can prevent you from taking the quality care that you want to in the moment. And so one of the things that I feel truly blessed in is having my experience with health system science, and to look at things from this like citizens system approach where we're trying to blend the two together. And then when I think of community health, I think, we're we can be very diagnosis driven, very evidence-based, which is a wonderful approach to individual care. But when you look at public health and all the factors that go into someone's overall health, and I do a lot of this work with trauma-informed care, you realize that research is actually a unique and critical way to bridge the two together. As providers, we tend to be very evidence-based. And what I think we need to do a better job in is expanding which is one of the reasons I was so excited to do this presentation with Kathy, is really to expand and take advantage of the opportunities to work with all of the other disciplines within our hospital system and within Virginia Tech in order to really affect change in a more impactful way. And so this also includes creating, touch points, access points, working with community leaders, nonprofits, primary care providers, really so we can speak the language of the community and so that we can really fully understand what their needs are. And I think by the time we analyze this and start collaborating together, we could really get through some of the barriers that exist from the community into the hospital system. Is this one mine, Kathy? I think so. So why community-based research and DEI? These are complex problems. When someone comes in to the hospital system, and Kathy and I were going back and forth over the last couple of weeks with all of these examples that we know of, when someone comes into the emergency room with diabetes that's not controlled, or someone comes in and we talk about their compliance and their ability to take care of themselves. These are complicated problems because we know it's so much more than what we're seeing and the picture that we're seeing. And so having a community-based approach where we're gathering different areas of expertise, different people from the community to address complex problems makes more sense. Then we gain a better understanding of perspective. We really can move the needle and deliver more quality and tailored programming and have solutions that aren't just hospital driven, but really community driven and focused. And they have relevance. We will kind of talk more throughout the presentation about evidence-based medicine and whether or not it's truly evidence-based for the population. Because what we see is that when we have done research in the past, there's a lot of room for improvement and there's a lot of room for growth, because maybe the types of studies that we've been doing in the past and some of the ones that we're continuing to do now aren't relevant to the patient population that we want to focus on, and they're not applicable to all of the patients that we see. And the other thing is it really allows us to optimize and maximize our resource. As a provider, I constantly feel overwhelmed and kind of stressed with not being able to meet everybody's needs. And through community-based research and through work with nonprofits and community leaders and people like Kathy Hosig, it makes me feel hopeful that there are resources out there that already exist. And it's really a matter of connecting patients to the right opportunities to make them successful both in and out of the hospital. And it really increases our capacity as providers to influence change. And I think it's really the kind of the panacea for alleviating some of the healthcare disparities that we see that we just haven't been able to kind of move, like things like maternal mortality, diabetes, obesity. And it's really about meeting the needs of the community. And I think gaining a better understanding of that will help with some sustainability, because it's up to then when you make the community a part of the research and a part of the formative process, then you also are investing them into the work that you're doing and teaching them and educating them how to take that and bring it back to their community. And so you really form this kind of mutually beneficial relationship.
And if you'll keep it on that slide, oh, you're not done yet, but
Yeah.
keep it on that slide when you are done, because I have a
Yeah.
couple of comments.
Yeah, please go. Feel free, Kathy.
Oh, please don't let me interrupt. And then
No, go.
Okay. Well, I was just thinking about conversations that we had at whatever time of day this was in the last 24 hours that is relevant to what you were just talking about, and it makes me think about, we're talking mostly about research right now, but thinking about trust in the healthcare system and how that also is related to any kind of clinical or practice-based research that we would want to do. And the conversation that Jaclyn and I had about the messages that we send to people who have Medicaid insurance and the policies around no-shows and being late to appointments. And I had started the conversation with an experience a decade ago when we first had foster children in our home who were on Medicaid and took them to a pediatric dentist. And the first thing the person said when I checked in was, if you don't come back next time, then you don't get to keep coming here. It's like, it took me a minute to realize, oh, it's because the child has Medicaid that they made that statement. And then and you'll probably do a better job explaining what you mentioned, Jaclyn, about how we've lost people who are on Medicaid coming back into the healthcare system post-COVID because of things that happened during COVID, as far as lack of services available because of COVID. And all of those things are relevant, I think, to what we're talking about here, because the system treats people as a group based on things that they have no control over. And if we could make it easier for them to keep their appointments, find out why there's this problem, not just say, we're going to punish you with this system because we need to be sure we have enough people in the clinic.
And I think it kind of, the last thing that came up on the slide is just about, when you have guided interventions, but are really policies and procedures that you put into place, and they are to elevate the voices of the community, you really realize that some of the policies or some of the research that we've done in the past, even though the intention is to create more inclusive and better access to care, can really put barriers that we just don't have a fully understanding, awareness about. One of the things Kathy and I talked about was, during COVID, a lot of the transportation services cut down. And so we had some moms walking to clinics. and walking to clinic with their children, and we had childcare closed down. And part of being scared and taxed as a hospital system in that capacity was, how do we deal with people that are not coming to appointments on time, that are showing up with their children when we know that they're not vaccinated? And I think that there's room to be reflective on what we did and how we can continue to open up those barriers and really kind of build some trust in the hospital system. And I know there's a lot of people right now at Brilliant really actively working to do that in the community. And I think it starts with kind of these conversations and then really trickles down to research.
Thank you. This one is mine. It's sort of what I do in my research agenda is community-based research. And so I wanted to include this slide, and it's from one of the articles that we sent out ahead of time. And I really like the article. I really like this graphic just to show you the continuum of community engagement and community-based research, where we just sort of pay some attention to the community and say, we're going to involve you and let you know what happens, all the way to the far right on the screen, where we actually work with communities over time and learn what's going to work in those communities and how it should be done. So it goes from informing, consulting, involving, collaborating with, and then empowering our communities to actually have a voice, a true voice in what happens, so that the researchers don't have this approach that, well, we're going to listen to you and then we'll take parts of what you say if it fits what we want to do. And that there's efficiencies along the way that we think, oh, we just need to move on. But if we do that and it's the wrong thing, then we really lose time. So we can think about it that way in terms of efficiency. But then this relationship that we spend time on and we build and show that we're listening and we're actually empowering the communities that we're working with. Again, community is very, very fluid in how we define community with this work. But if we truly involve the communities that we're working with, that's going to pay off in the future, because it'll be a lot more, a lot easier for us to find out, okay, now the community wants to work on this. What is the best way to do it? We don't have to spend years developing a different relationship. We have a relationship on which to build. And perhaps we want a different subset of the community because it's a different health issue or a different health problem, but we have standing in the community. We have people who can say, these are good people. These people are going to listen to you. Please come to the table and work with them. And you don't have to continually try to develop these very cursory relationships or superficial relationships to do this little thing that you're doing now. Overall, it's the big picture, and it does pay off. It has really paid off in terms of efficiency, actually, but really impact of the work over time, because of the trust that's built. And it may not be the same people you work with each of the research projects, depending on the kind of research you do. But like I said, those people know other people and they'll vouch for you. Even if it's not in the same county or the same exact neighborhood, you've got people who have worked with you and can help you find other people and build that trust more quickly. Okay.
So some of the elements of community and DEI engagement. So, you're going to hear a common theme of trust and what it means to trust the community. I think back to right when COVID hit, one of my patients, I had diagnosed her with an ectopic pregnancy and really encouraged her and recommended that she come into the hospital system. And she was from 2.5 hours outside of Roanoke, and I had seen her for the last 2 years. And I remember speaking with her in the heart of COVID and in the heart of really Black Lives Matters when it first started. And she told me that she was scared. She trusted me, but wasn't sure how she trusted the community and how she trusted the hospital system. And she was listening to her own community that was telling her that that's not the right place to go. And it had nothing to do with Brilliant. It had nothing to do with the health system, but more, and this is kind of a top-down approach, but really more some historical context that we really have to kind of think about. And so building trust is really the key element of engaging the community. And having respect. I talk about this a lot with the students, especially in research. Sometimes if you don't understand the cultural context, Sarah knows this, but it took me a long time. And if you know me at all, it's not a shock that I do a lot of women's advocacy. work. And so for me, sometimes when there's a cultural dynamic, when I hear, the husbands speaking up, or the wives not speaking at all during a visit, it actually took me a lot of bias reflection to think about and figure out how I can respect that relationship. And that it wasn't about how I wanted to communicate, it was about how they wanted to communicate. And so sometimes even I've been thinking about that with my own research and trying to do, if I had a couple of students ask me about refugee research, and I thought we're going to have to really have a roundtable conversation and to frame this completely different, because even though the patient is going to be a woman or their wives, the primary person controlling these decisions is going to be the husband. And how are we going to use that in a formative way to really kind of change our study design? And so, part of that is creating shared missions, hearing what the needs of the individual is and what the culture is and what the community is, and figuring out how we can create a shared space, especially when it comes to research. And again, having that cultural sensitivity and humility is something that Kathy and I think is another theme. I think back to the research that I did even 3, 4, 5 years ago that's now coming to fruition in poster presentations. And, I've spoken to the students about, I just don't want to publish it. And I don't think it's right because it wasn't done in an intentional and a meaningful way. And so some of that is being, humble and recognizing that learning about community engagement and DEI is really a continuous journey, and it's okay to not get it right, this time. And this conversation hopefully sparks change to move forward. But one of the key elements too is that it's very cyclical in nature. When I first got into quality improvement work, one of the things that I loved was this PDSA cycle, this opportunity to be very formative and, go a couple steps and then change the process based on the feedback. And that's really what talking to and engaging with the community, what works, in the cities, in the eastern part of the state is not going to work in the Southwest Virginia. And I have this conversation a lot when I sit on advocacy committees. And that's really important to kind of engage the community and think about how can this be sustainable in creating a framework that's adaptable enough to be used in different contexts. And one of the most important things I think as well is just consistency and transparency. And I find that's a really big challenge where you're really combating some of the stigmas that exist just between the overall hospital system in general, regardless of the hospital system, when you're breaking down the stigmas of the historical context of research and experimentation for some races and cultures, you really have to open yourself up to some opportunities for transparency and communication. Feel free to chime in, Kathy. Whenever.
Yeah. Related to that, as I'm starting to talk about this slide, it made me think about how grateful I am when people that I'm working with in communities feel comfortable enough to tell me that I screwed up, and it's important for me to let them know that I want them to do that I appreciate it. It really is a compliment to me when someone that I'm working with from a community lets me know that there was a misstep. And I think that then lets them know that they can trust me because I don't react in a negative way. And so I learn every time almost I'm in the community. You'd think I would have learned everything by now, but I haven't. And that really does go a long way, that ability to have that open communication, and it really helps to build trust. And so we have a couple of slides next. One is barriers to community engagement, and then specifically to DEI on the next slide. But you can see all of these things are related to what we've already been talking about. And time, again, is a huge one. Making the time, allocating the time. And some of us have barriers to that from our work setting. We need to move on. We need to move on. We need to pump out the grants. We need to do all these things. And it takes time to build trust. And we want to be sure that we do that intentionally. But sometimes that time that we build trust, during that time, we're not doing some of the other things. But again, like I mentioned before, that time investment is going to pay off. both just personally in your relationships, but also in the work that we're doing. But when we think about it more community focused, even, there's obviously, we have competing priorities, but so do our community members. And so we need to honor that as well, and just find out, is this something that is a major issue for them, or is there something else that we need to help them deal with first? That's one way with the competing priorities, that when we work with communities, we need to listen and see where what we are thinking about fits into how the community is feeling, which then bleeds into the next one. And I left in the word stakeholders, but I did want to take this opportunity to say that in public health, we are trying to figure out what to use instead of stakeholders, because that has become, we've become aware that it's really not the best word to be using for a variety of reasons, but primarily thinking about the Native American communities, who that stakeholder term is really kind of it is an affront, because, laying claim and staking a claim. So we're using words like affected communities. Nobody's come up with a really good one, but I wanted to just point that out to this group, because I try to do that when I'm speaking to groups, that we're looking for a better term for that. But the point being of that is that there are people who are going to be more affected than others by the research that we're doing, and we want to be sure that they are allowed the opportunity to understand where we want to go with this, and find out where they want to go with it, so that we have buy-in is a bad term too, really, just thinking about their partnership and collaboration, and that it feels right to them. And I'll go a little faster on some of the other ones, but resources and time, that's always a barrier on everything. Capacity building, I put researchers first there, because that's something we do in the center, is try to make sure that our researchers have capacity for community engagement before they start to work with community members. So it's a bidirectional and cooperative situation, and both researchers and communities need to have some time to learn how to work together, just like in group projects. Jaclyn and I did a great job learning about each other and working on this group project together, but it took some time even for that, even though it was like intense time right at the end. But learning from each other and about each other, and capacity building for being able to work together. And some of the other items will go into the next slide as well. But communication, we can tell that that's true during all of the things that we've already been talking about. And that means not just telling people what we're doing, but listening about how that might affect them and what they think we should be doing. So again, that bidirectional communication is really, really important. And always keeping our communities abreast of where we are in the process. And if nothing is happening, tell them nothing is happening. I've been too busy. And so don't go a long time without some communication, because that does not build trust. They need to understand where we are and what are the barriers in moving forward, and all of that. Related to the lack of awareness, understanding is part of that capacity building, that researchers who are going into communities, are beginning to work with communities, really need to listen first, and find out what's happening in the community and how we might help with health issues in that community. And then I'll leave it at that, and we'll go to the next slide, because it comes forward there.
We intentionally kept the slides the same, because when it comes to barriers that we face with the community, very similar barriers when it comes to DEI engagement. Something that Kathy said reminded me while I was at this conference, the first speaker, the plenary speaker that opened the conference, it was about health equities, the conversation. But one of the things I think she did was talk about her positionality and the privilege to even speak. And she paid tribute to the land that we are currently residing on at the conference. And it was a really sobering moment for me, because it was just, again, someone who really tries to practice what they preach. It's just, I'm constantly learning every day something new and something important to incorporate when I'm speaking. And it reminds me of something that Kathy said, that is just, I also feel the same way when I misstep. When my patients tell me, I think, okay, I'm doing a good job, because if they're open enough to tell me, that means they trust me enough, and they want to build, and they want to make me a better physician. And so it allows me the capacity to do better next time. And so even just the word stakeholders and buy-in, I mean, in the nonprofit world, I work a lot, and we have these conversations all the time. And I will definitely be removing those from my slide deck. And so really kind of the big touch points here, because we all have that, it's interesting. We're all competing for grant writing opportunities, research funding, resources, time constraints, no matter what your work ethic is. And those are, when it comes to research, those are often huge barriers. Some of the pilot research and even, we are received the I Thrive this year, and we were discussing that if we hadn't already had it IRB approved, would this be a feasible timeline when you're talking about maternal health? Because patients are pregnant for 10 months and, 9 or 10 months, and you're trying to, see change over time. And so part of that is this time crunch. And sometimes you have these funding allocations that are limited in what you can do with them. And for DEI, one of the things, again, is it's so hard. And I think we talk a lot about cultural competency, and I think there's a lot more of just cultural humility, because there's a lot that we don't understand, and there's a lot that we don't know, and there's a lot of privilege on the provider side. And so part of that is really engaging with the community just to gain a better understanding and awareness of their perspective. Social determinants of health and access to care, especially when it comes to research, are barriers. It's a big ask when you have somebody coming to their appointment to ask them for one more thing when they've already taken 3 buses to get to you, or driven 3.5 hours to get to you. And so really kind of when you're thinking about your design and your research design, what are the ways you can optimize the things that they're already doing that's already part of their health plan? And so that's why I love some of the community research where we're going out into the community and making it happen at already existing things, like using faith-based leaders, already existing town halls, bringing things into school systems, because that allows us the ability to optimize the space that they're already in instead of doing one more ask. And then really historical and existing racism. I'll talk a lot more about that when it comes to some solutions. But I think especially when it comes to obstetrical and gynecology care, there's a lot of systemic racism that still exists, and it's very pervasive in the research that we've done and some of the policies that we've done. And again, maybe not with the intention that we had hoped, but still, harm there nonetheless. And so it's going to take us a long time to break down some of the stigmas. I was reading a statistic yesterday that 82% of transgender patients, I have a lot of transgender patients, report harmful or negative experiences within the hospital system. And there is a recent study that came out in January that said that they have to have, on average, they have to have almost a 9 out of 10 pain to come into the emergency system. Which I think kind of speaks to the fact that we really need to hear their voices. We need to hear what their concerns are and why they're not coming into the system, because they're truly, like many others, a marginalized patient population.
And if you think about what Jaclyn was just talking about, and then think to the research, if we invite those individuals to be in a research project, why would they trust that they would be treated well? Or equitably. So those two things are connected, I think. We have this list of some things that have been proven to be effective for community engagement. I'd like to just sort of think about them as a group, and they're on a continuum of intensity and length of time in the community. So sometimes we do need to have a quick, let's get the pulse of the community and see where things lie and get some informative information for our research project. But even with that, if we use that as our first touch point and then continue a relationship, so we might do a community meeting, or we might do a community engagement studio. We'll talk quickly about those soon. Then that gets us a beginning of a relationship. But the trust comes in staying in that relationship and continuing. For that third bullet, for example, going and volunteering and feeling a need in the community, unrelated perhaps to the research that you would like to do with the community, but different ways of interacting with the community, learning from the community, listening to the community. All of these ways are good ways of doing that. But one thing I want to mention, and it's probably on another slide too, but I just want to mention it here, that establishing new groups, we only do that. In fact, I think if you want to go to the next slide, I think Jaclyn
Yep.
is probably on that one. Let me see. I hope I didn't think about it. Yeah, thinking about meetings and town halls. We'll come back to that in a moment. I'm sorry to do that to you. Let's do the establish new groups. So
Okay.
these are all the kinds of groups that we might establish. But what we found over and over and over in community settings is that is a really tough thing to do, especially in small and rural communities. And for the reason for that is they're all on all these other community committees and coalitions already. So that's why on that initial list, we don't have to go back to it. I put in there, go to other meetings, go to other coalitions, get on the agenda for other groups and other meetings and groups, because that's the way to start understanding all the other issues that are in the community. And there might be a reason that there needs to be within a coalition, a task force or a smaller advisory board, if that group endorses that, yes, this is something our community is interested in. So it starts with doing small informational sessions, maybe a town hall meeting, those things, but also going to other existing meetings, really being out there present and learning from people and having people meet you. That really, really helps a lot in terms of establishing trust and really understanding the community. If we can go back to the slide right before this one, I think. That one we had, and I can't remember if it was Jaclyn's or not, but I'll go ahead and talk about it because I'm already talking. But again, the public meetings and the town halls, the main thing on this list I wanted to point out, because we've talked about some of the other things, is the last two bullets, the address concerns and barriers and identifying resources, because that is something that I've seen in many of these meetings that I've either held or gone to, is that the people who come to these meetings, they don't need to be told this is a problem. They don't need to see data necessarily about how significant a problem this is. They're there because they know that, and they're trying to find ways to deal with that and strategies to address it. And if you just hold, and this happened to us in Petersburg recently with the governor's initiative, I was there present because I've been working, and people came from the governor's office. I'm probably shouldn't be saying this, but anyway, they came to the governor from the governor's office to tell the people in Petersburg about all the things that are wrong or problems. And they're trying to make solutions, so that's good. But the point being, really listening about the problems and what's going on, and helping to identify the resources and addressing the concerns. That happened when I was going to opioid related 4 years ago, town halls in Martinsville and also in Roanoke. I saw this happen where there were moms of kids who were facing addiction. There were people whose family member had died from opioid use disorder. And they were there to talk about solutions. And it was all about, let's talk about the problem. And so that's just something that I wanted to mention because I've seen it over and over again, that you have to be prepared to at least talk about what are some potential solutions when you have these kinds of meetings.
We talk about the same thing when it comes to health equity and DEI and just chronic disease in general. I think, we do spend a lot of time, I think, even as professional, providers, in telling patients about the problem. We're very focused on the problem and the diagnosis. And I think that we need to really move towards more solution. And we are trying to do that, but more solution driven and really asking the patients. I'm always surprised. I told Kathy that story yesterday, but one of our patients who, of course, had the label on her chart of non-compliant diabetic patient, very well documented in her chart that, the risks of her baby dying and the risks of her going into preterm labor and stillbirth. And because she, was not taking her insulin. And it took a couple of times of her coming into the office. And the other day I said to her, is there something I can do to help? Is there a reason that, and she just said, I can only make this appointment late. Medicaid takes me here. And by the time my dad gets off of work, there's a pharmacist shortage in Northwest and I can't get my insulin. I've tried 6 or 7 times. And we called it in quickly to the downstairs pharmacy, and she's been compliant for weeks. So sometimes when you just kind of ask the patient, and I think this is really what speaks to why you want to go to these public, and I would agree with Kathy, it's not really creating new groups. I think that's something we love to do from the top. Like, let's create a task force. Let's create this. The truth is the community is already talking about it. And if you engage with them and listen to them on what fits best within their community, the solutions are kind of handed to you, which is nice if you think about it that way. And so one of the things I wanted to plug to here, Curlian has a wonderful, I think, untapped resource called Employee Resource Groups. And they're for anybody to sign up. I don't know if Brianna is on the call, but I asked her for the link yesterday. Because these are groups of people that are already doing amazing work in the community and want to stand as representatives and want to elevate the voices of their community. And so they're great resources if you want to do research, just to kind of gauge a better understanding of who that catchment area is, what's already being done in that community, and what the community's needs are. Because when you kind of look at some of the community needs assessments, historically have not really been generalizable to the overall population, right? Especially when you're looking at social determinants of health. And so, you know, Kathy and I have already talked about it, but one of the biggest things when you're in these environments is I just wanted to kind of put a plug in, and we talked about, you know, the difference between stakeholders and things like that, but really having person first language and asking patients what they like to be called and how they like to be addressed and the manner at which they like to receive information. Those words really, really matter, and they make a huge difference. We are trying to get a study up and running right now for blood pressures. And when we started talking to the community, that's what we did. We went to one of the town hall meetings and we found out that most of them, a lot of them prefer to communicate through WhatsApp, which is challenging when you're talking about research and IRB and HIPAA and liability. And so really trying to figure out innovative ways with that community on how can you use the tools that they're already using to communicate, to incorporate that into your research design.
And I'm going to breeze through this one because I think we're so enthusiastic. We're probably taking too much time on this.
Sorry,
But
I just realized that.
no, it's not. It's both of us. But I wanted to just mention community engagement studios because we do offer those through iThrive that I mentioned. And it's similar to a focus group discussion, but much more targeted and really to help form research direction and inform how to do the research. And so I just wanted to bring that up if you haven't heard about it. And please feel free to email me if you're interested in doing this to help get started on community engagement in your research, because it's a really good way to get started on hearing from members of the community that you would like to work with about what matters to them and how the research should go. It really is helpful to form the research questions, how to do the research, even consent forms, things like that. And we can move on. And then data collection, I think, is mine as well. And I'm going to breeze through this one fairly quickly, but it's just a way of, if it's done correctly, all of these methods that we're all used to are ways of learning about the community. And I just wanted to put in, and you'll see a couple of examples or one example of photo voice later, but there's so many different ways we can work with communities in terms of data collection. But the thing we don't want to do is go in and collect data and never tell them what we found or never give any kind of feedback, and to use that in a very intentional way, the data that we have, and go back to the community members who provided the data, but also who would like to know about the data, and tell them, what did you find and what can we do with the data? What can we learn together with the data that we collected?
I love that. I think that really makes them, closes the loop and makes them part of the solution. I think just the other day, I had a patient who was newly pregnant, and I did a placental microbiome study years ago when I first started. And so that was 4 years ago. And that was the first question she asked me at her prenatal visit. She wanted to know all about it, what we found. And so, and it hit me, okay, that was research that I did a while ago. And now I would never think to do that, to not, report or to talk to my patients about it in hindsight, because when you make them part of research and they're engaged, it's very exciting for them. And so really to kind of that close the loop there is an important component that I think sometimes we're missing.
Yes, I forget it all the time. And people, and again, they tell me, hey, you screwed up. What happened? We need to know.
That's a big one. That's a big one too. And then just effective DEI strategies. So for the sake of time, we'll kind of breeze through them and I'll try and hit some touch points. But the ones we're going to focus on is understanding some historical context, standardizing sociodemographics, and then inclusion and exclusion criteria. So For me, and again, it's Women's History Month and it was just Black History Month. But for me, one of, I think, the hardest things that I've had to go through from a patient perspective and a provider perspective is just really understanding that systemic racism and experimentation and sterilization is a large part of the history of a practice that I love. And so it's sometimes hard to listen to and hard to hear, but not recognizing that, not respecting that, and not thinking about that when you're doing the research and when you're trying to engage in the community is really kind of doing a disservice, I think, to your own research and your own mission and how you take care of patients. The picture, I think, on everybody's right or left of the two women up top, this is from 1924 and was one of the first women ever sterilized, and a forced sterilization because she had epilepsy. And so, right, that is a society's view of who and what and how they should receive care. And that, even though it feels like so long ago, right, over 100 years ago, we still see themes that are similar when you're talking about reproductive health rights. When you talk about some of the recent articles that you find and the recent publications about pain and how we perceive pain based on color of skin and based on some implicit biases that we have. So really important to kind of realize and recognize what some of our biases are in going in and formulating your research design. And I thought this was so palpable, but Elsevier during the pandemic in 2020, throughout the Black Lives Matter, when this really, even though a lot of us in public health have been talking about this for a long time, especially with research, kind of really put out a statement that I thought hit home, and just apologizing and saying that they've played a role in some of the systemic inequalities that exist in evidence-based practice. And really that we're incumbent to change these study designs. And so that's really kind of what this conversation is about. One of the things that I wanted to show, I think this is such an easy example. So if you want to go into the weeds really quickly, just Google demographic data for surveys. Even the most recent published surveys or the most recent studies with demographics. It's very interesting. The studies that we take and apply to the general population, even though they are not generalizable, is kind of astounding. Even when you look at something as big as cardiovascular disease right now, right, which is the #1 killer of women, over 86% of the studies over the last 20 years are focused on men. And so, and when you look at the gender, right, male, female, and you just dichotomize them in that way, most of the studies, over 80% of them, are only done on males. And so are we really able to take a lot of the guidelines and policies and procedures that we've created over time and apply them? And what we're finding is that we're not, that women aren't doing as well with some of the interventions that we've created. And so just kind of an interesting take on even, and this again is a point of humility for me, and so just learning what I didn't know before. But this is an example of one of the school forms that I just filled out recently. When you look at a piece of paper and there's gender, which is often mischaracterized, right? And there's only 2 options. And then you progress, right? And so when I look at my studies, I didn't even include gender or sex on my earlier studies because I thought about in this one-dimensional way who my patient population was. And then I kind of progressed. These are, some examples from studies that I've done within the last couple of years to talking about birth sex and current gender identity. And then they've really evolved and moved, and that's okay. They're supposed to do that. And so what I encourage you to do is even broaden and open up the idea of, and I hear this a lot, well, it'll skew the data. Well, there won't be as many touch points. Well, it's a lot harder to kind of prove. But I think what we are doing is limiting our ability to take this and apply it to the general population or to specific communities really marginalized or in need. And so my last blythe about sex is not gender. I see this confused and a lot, especially in research. And so the last thing is really when you talk about inclusion and exclusion criteria, I find this a really interesting, even just terminology when it comes to research, right? In the clinical world, we think very basic about what's included and what's not. But then when you get into the weeds of this, right, this is a cultural change for us. And this is a cultural, something that's pretty pervasive that I don't think that we realize. But are we excluding based on the easier path? So I told Kathy, if you look at my earlier work, no one, I don't have anybody in my IRB that doesn't speak English. And that's something that is shameful for me. And I did that because I thought it would be easier to go through the IRB process. I thought the research team would be at capacity. I thought it would be harder to do consents. And so what is easier isn't always the correct method. And is it an easier path, or is it there just a barrier that you really need to break through? And is the exclusion criteria based on capacity? Is it based on implicit bias? So again, if we have done studies years and years and years, and the amount of Spanish-speaking patients or the amount of Black women have not been, equal in standards, can we take that and call it evidence-based medicine? And so I question you to kind of take a look on what that means and how we deem inclusive. One of the things that we talk about is the HPV vaccination. When it first came out, we wouldn't give it to anybody over the age of 26. And the idea was, well, everybody has an exposure to some type of sexual activity before the age of 26. Do they? Do they though? And so, it was that way for a long time. And even now we're still trying to kind of navigate that in women's health. And so just kind of a push to think about how we're defining inclusion and exclusion criteria. So we have some kind of applications. I don't know, Kathy, do you want to wait for questions? Do you want to talk
Maybe
about?
we'll do them at the very end, so we just have a couple minutes each for the application. Yeah.
So one of the things that I do, I'll try and do it in less than 2 minutes. So one of the things I try and do now that I didn't do before is anytime I write a grant or I write a study design, I try very, very intentionally, which is a lot more work, I'm going to be honest about it, to include the community. And I do that by being formative in the research and design. So when I write the grants, I try and write them to have funding allocation for things like translator services, access to care, a way to give patients what they need to participate. I think about elevating the voices of already existing resources. So I usually write them so that way we can pay and give both fiscal and resource support to things like Casa Latina, to people like CHIP, to some of the already existing task force that exist. And so we did that with our one of our curriculum redesigns for trauma-informed care. And what we did was we brought peer-to-peer recovery specialists and patients that were willing to kind of speak to us and receive training to be standardized patients. And what I was telling Kathy is we met with them a couple of weeks before the actual session day, and we wound up spending, oh gosh, it felt like hundreds of hours reformatting and redesigning the curriculum, because all of the pieces of information that they gave to us about how they wanted to receive care, how they wanted to be spoken to, the messages that they wanted to give to the students was just such a valuable piece of information that it wound up being the driving force in how we design our curriculum. And so part of this conversation is just to say, like, it's never too early to engage your patient voices or your community voices when you're talking about research and design.
And it can be too late. So it's never too early, but it can be too
Oh yeah,
late.
sorry, it's never too early.
No, you said it's never too early, but then I was thinking, but it can be too late.
Oh yeah, it's true. It's true.
If we wait too long, then again, we have to go back and redo it because we didn't do it right. So yeah, definitely the earlier, the better. And then I just have a quick example from some work that we're doing right now with cooperative extension. You can see this on my background. I'm a public health extension specialist, and we are doing some vaccine education work in partnership with the Virginia Department of Health with CDC funding. And our charge was to work with particularly vaccine hesitant rural counties. and underserved counties. And so through cooperative extension, we decided where we were going to work. And there's one county in particular in rural Virginia that is really vaccine hesitant, very low vaccination rates, and community sentiment is very, very against vaccination and talking about COVID. And so we were trying to figure, and our extension agent in the county didn't want to talk about COVID because of that fact, didn't want to alienate the people that she works with in the programming that she does. And so through United Way, we knew that people in this county were very much affected by COVID and mourning significant losses in their community. And they were asking for a way to honor the people that they lost. And so the two things you see on the screen, we decided to work with that and actually, again, learn from the community what their priorities are and what they care about. And so what you see there is the fall festival with the tree, the little tree with all the little notes on it. That's a story tree. And people were able, and over 100 people came in the small rural area at the fall festival to do this. And they wrote down how COVID pandemic had affected them and their losses, or positive messages about recovery, whatever they wanted to put. But there were over 100 little notes at the end of the festival. On the right side is a photo voice project where teenagers in 4-H and also from the high school took pictures of how the pandemic had affected them and their families. And then they come together with photo voice and talk about what those pictures mean. Those pictures are now posted at the public school board office, school division office. They wanted them there and they want to keep them there as a display of that project. And that has opened doors for us to work more with the schools that had been previously not too sure about working with us. So I thought those were some really nice ways to make the points that we've been making through this presentation. Now we have 3 minutes. We're sorry about that.
Sorry about that. Lots to talk about. It's a heavy topic. So we didn't know if people in the audience had questions or if these are just kind of some thought-provoking prompts. What are you working on? Who's your community? What challenges have you experienced? And would you consider kind of some of the approaches and solutions that we've given you? Would you consider kind of incorporating them to address some of those barriers?
And we do have an entry in the chat that I would like to read because I think it's a really good way to wrap up. It's and if the person would like to say their name or not, it says, "Thank you for this discussion. To be a DEI advocate today is difficult in some circles due to the anti-DEI, anti-woke sentiments expressed publicly by politicians to appeal to those who have latent similar feelings." And I think that is definitely something we're probably all thinking about who are on this call today. And I actually ran into a dear colleague in Kroger recently, and we were having the same conversation that has gotten harder recently to have these conversations and to be able to have these conversations together. Like Jaclyn mentioned, we probably all are of fairly similar mind on this call, but how do we work with in our communities where sentiments may be different? And I would say, again, being humble and having conversations and learning where these sentiments are coming from and having honest conversations is really the main thing we can do.
I do want to open the floor to folks who have questions. Feel free to put a question in the chat or comment, or if you'd like, feel free to unmute yourself and add comments or questions.
Kathy, I would just like to say I appreciate the chance that we happen to bump into each other and to be able to have that conversation. And yes, it is real, some of the pushback that I am starting to see and hear.
It makes hard work even harder.
Yes, exactly.
Well, I think both of our emails are in the chat now, and I think I can speak for both of us that we would love to hear from you if you have thoughts on this presentation or ways that we can help in the work that you're doing.
We're always looking to diversify our teams, so and for some open opportunities for collaboration. So we, feel free to email about that as well.
Thanks for mentioning the employee resource groups, and for sure we're certainly open and very willing and happy to work with anyone who might find that to be a good resource.
Thanks to you both. What a great conversation, wonderful presentation, so much good knowledge and important things talked about today. Can't thank you enough. To those of you that attended, really appreciate you being here. Do feel free to complete that CME evaluation if you have time to do so. And we'll be making this session available as part of our enduring materials very soon. So feel free to re-engage, tell your colleagues about it. And we look forward to seeing all of you again soon. Thanks so much.